Okay, hi everyone. Before we get started, I just wanted to mention that moving forward, at least for the time being, we're not going to be doing briefings with Dr. Williams and or Dr. Yaffe on Saturdays. That will start effective immediately. So we'll be sending a blast out to the press gallery towards the end of the day, and please feel free to circulate that within your outlets. So we're going to get started. Dr. Williams here today, half an hour, one question, one follow-up, and I'll turn it over to Dr. Williams now.
Thank you. Good afternoon. And as noted, we're on the data we're going to be sharing again today. As we said before, you're going to see fluctuations, and we're going to try and move more and more towards some trends and directions, just because I think the daily variability, if anything, puzzles people. But how does the overall trend and direction going? So with the data, like for today, as you know, yesterday we were at 399, and today we have on our data reported positive cases 477. So everybody say, well, we were down, now we're back up again. But remember that a week ago when we had this trend on the same days, we moved up sometimes over 500. So it seems to be like this gradually coming down. So I wouldn't get too discouraged with that. We have to see how that plays out over the next day or so as we're bringing in more and more samples. I'll talk about that in a moment. So that means we have a total of 19,595 confirmed cases of COVID-19 in Report Ontario since the outset in January. And so looking at that there, again, the demographics are just about the same. They're not changing at all. The male-female ratio, 15% difference, about 43% over 60, and still around 61% in the Greater Toronto Area Public Health Units in that regard. So the number of healthcare workers is 3,230, and that's a cumulative number since the beginning. And while we're seeing lots of Ontarians recovering, with 71%, that's 13,990 that have recovered or resolved. And as I said, that makes up a large proportion of Canadians resolved in the overall data on a national basis. So that's the good news. Unfortunately, we still see some deaths related to COVID-19. And as I said, we had 63 reported yesterday. And unfortunately, we've had another death related to our long-term care staff, another personal service worker, unfortunately. And again, that gives us 4 in the total of that area there. And that's, again, unfortunate and sad in that regard, and condolences to the family in that aspect. I should mention that at the hospital side, a few people, a little drop in 5, not amazingly high number, 1,028 in all the hospitals at the moment. The ICU is down by 7, and those in ICU on the ventilator was up by 11. So it's going back and forth there, but staying on that plateau, gradually coming down level in that regard. Yeah, as I said before, in the long-term care home, besides the 4 healthcare worker deaths, with the additional new one, there are 175 outbreaks. That's an increase of 1, although there have been a number of resolved cases already in that aspect, with 49 outbreaks have been resolved up until this time. As far as the positive cases there, we saw some more data correction aspects in that regard. So the number of residents positive actually dropped by 49 fairly significantly, and that's because that they had received, as you recall, with one of those testing zones in the eastern part of the province, had some false positives, and that's been rectified. There were still 36 extra staff, so while the delta of cases in the long-term care in this report, long-term care report, decreased, you can see why it's a difference in data accuracy and cleansing, I would call it, and rectification. The retirement homes, we had 69 outbreaks. That's an increase of 4. Again, there's a lot of data rectification there, with a negative 75 residents and negative 13 staff. So that's an overall drop of 88 cases in the overall total. And again, that's the data rectification that we see going on in that administrative data. They had, unfortunately, 3 more deaths reported related to COVID-19 for a total of 155. On the testing side, we're getting close to 400,000, 397,149 tests. Yesterday, in the 24-hour period, we had completed 16,295 tests, and there are still 14,641 pending. and a fair number still coming in. As I said, this is the ongoing survey in the long-term care facilities of residents and staff, and a lot of samples and that being done. Looks like by the end of this week, as we had hoped, we're going to be at the 50% mark, maybe slightly higher, which is good, seeking to complete the whole task of all homes by the end of next week, Friday of next week. So that's the target and goal in that regard. So, as I said before, the general direction, as you can see, the lab tests to go up and down cyclically in the week, and dipping down on the early part of the week because of the weekend timing, and then goes back up again, and then goes back down. But in that overall trend, how's it doing? And then we want to look at also with the cases reported each day. While it has some ups and downs, we see the general trend is a plateauing, so not a rapid drop, but certainly not increasing overall. The positivity rate as well in the testing had dropped down to 3.5%. So that's one of our lowest positivity rates we've seen. Again, that's a blip down. Let's see if that's sustained, because we had been moving steadily down below 5% earlier in the week, and that seems to be more of a, I would say, a trend positive direction in that regard. So we can watch that, as well as our knot we talk about, our transmission rate. For the overall province is about 0.9 with some variation around, with some as high as 1.3 and some as low as 0.8. So overall, I would say staying steady with a gradual plateauing and coming down, not as rapid as we'd like in that regard, but it's moving in the right direction overall. In there, we've seen some more, as you said yesterday, some more announcements with some greater availability of curbside for retailers on Monday in that regard. And just the general messaging still for people, even though the weather's not going to be very warm, I hear, to still you can go out, spread out, as I say, go out, spread out, and be careful and keep COVID out of your life and out of your home in that sense there. So keep following the messages, keep doing what you're supposed to do, and enjoy as much as you can, regardless of the weather. And we'll be seeing how we do next week, if we can still make even more progress on planking or bringing down that curve in the community spread numbers there. So those are my comments. So I'm going to go over to media for questions.
Okay, we'll move to the phone lines.
Your first question comes from Sean Jeffords with the Canadian Press. Please go ahead.
Good afternoon, Dr. Williams. Wanted to ask you about some of the concerns that QP Ontario is raising about the availability of N95 masks to workers in long-term care. The government's confirmed today that it is talking with unions about trying to control the supply. I understand it's quite limited. But the unions say that that will actually not help workers at all, that this further puts them at risk. And, you know, I guess I'm wondering, from your perspective on this move and why it's necessary.
So I'm trying to sense the move here. As you know, the direction, there is the directive number 5, and in light of the ongoing supply demand, with more and more facilities wanting more and more PPE, and the change in the demand with new orders, some domestic discussions about production and reprocessing. So there's a lot of dynamics going on there. And my understanding, because I wasn't at the table, that there have been ongoing discussions between the unions, multiple, and the government in regards to Direction 5, and that is still ongoing. So I have not been informed yet of the final result of that discussion. I think there's still some other aspects pending on a go-forward basis as we seek to balance between ensuring the safety of workers and still having adequate supply, so those that are in real areas of high concern will have the sophisticated PPE when they need it for their protection, and yet other ones, so there's a combination of conservation, other supply means, different methods to keep that supply and demand thing balanced so that we can continue to ensure the safety of workers. As I said before, I am aware that there is ongoing discussions at the table and will be informed accordingly.
Follow up?
Dr. Williams, the union also says that even with the current directive that's in place, it's actually quite hard to get N95s for a lot of frontline workers, PSWs. And they say that, often when these workers ask for them, they don't get them. They're denied. I'm wondering what your reaction is to that, and is there anything the province can do to work with employers or order employers to give these masks to the workers?
The command table has a number of tables. One deals with the supply and demand of PPE. The other deal with the various sectors. There's a hospital one, and there's of course, the long-term care table under Dr. Smith. That's looking at that in conjunction with the Ministry of Long-Term Care. So I'm aware that any of those demands and different issues are dealt with on a case-by-case basis. So I think they would try to ensure that where it's really critical and necessary, they would have that available. But again, the actual case-by-case one, dealing with the outbreaks and the other homes, is being assessed, as I said, on a case-by-case basis to ascertain the need as well as to ensure the supply. So that's the overall general direction that I'm aware of from the command table.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hi, Doctor. It seems to me that the numbers are fairly persistent here. And in terms of community spread, you said about half are long-term care, half are community spread. Wondering if you've considered and what you think of the idea of putting people who live with other people, like, moms, dads, whatever, in hotel rooms so that they don't keep taking this home, because it's so contagious. It always seems like other people in the house get it. And would that be a way of cutting down this transmission?
So it's a good question. I think the way we're looking at there in the past, when we had the travel history, that remember, people would come back and the household, the couple would be in the household. If the one turned positive, that person would seek to isolate within the house from the other members, and the others would carry on ongoing monitoring, and if they became symptomatic, would get tested as well. So we did that for the first part, especially all during February into March. That worked. I think what you're asking about and what we're trying to really get to here is, because there is some sense of people that are pre-symptomatic that are actually transferring, so you'd have to know before you knew to go to the hotel, because you've already spread it in contact with the people in the household. So in a way, going out after you have been identified positive is a little bit late, because you've already contacted with the other people and you're going to monitor them anyways and test them. So it really gets down to our case contact management, where we're trying to get back to and asking, if someone in that setting is positive, where did they get it from? Because you'll check all the other people in the household, and if they're negative, or you may find someone's positive, and they may be the incident case, not the person that has the more symptoms at that time. So it's I think doing that may solve one thing. It doesn't really solve the big issue overall in that, and people doing the physical distancing and then the monitoring and the testing in a timely fashion. Because even if you're in that group, if it's one member of the household and they've been saying that they have been in that 6-foot distancing for the period, someone had to get it from someone outside. And someone maybe inadvertently, or wasn't aware, or maybe was less than vigilant, had contacted someone who later was identified as a case and brought it into that household, if you may. And that's what we're trying to really get people to say, well, your behavior is not just yours, it affects your bubble or your group, and you have to take that seriously, because you can expose the whole group even in the early stages of it and contaminate them. Even if you say, no, I'm symptomatic and tested positive, that's 4 or 5 days later, so everybody has been exposed, and we have to monitor them and see if they develop symptoms. So going to the hotel at that stage is like a little bit too late.
Follow up?
Okay, thanks for that explanation. I was just wondering, since China seemed to do a lot of that back in the day. Just a quick follow-up. During the Premier's news conference earlier, the health minister was saying she wanted to get testing over 20,000 a day. So I wondered if you folks had new higher targets that you're going for, and what you think is an appropriate level of testing going forward once, for example, in a few weeks, presuming we get the stores open more widely, how much testing will we need to be doing?
Right. So I think what the minister's alluding to, because remember last week we said our maximum was 19,500. So this week they've done a bit more nudging on that. So now the new max is around 20,697. So it's nudged up over 20,000. So every time you get this, gives a bit more room. We're wondering how we'll do this week because we did just over 16,000, and we have 14,000 pending with a lot more coming in. So I'm really watching tentatively to see how we're going to do on samples tomorrow, because tomorrow's will be actually Thursdays, and see if we bump up very close to that 19, maybe potentially getting over 20. So let's see what happens. But again, it depends on the flow of the specimens, et cetera, in that regard. I think our main task is to get through the survey as required. That means all the homes by next Friday. So we've done over 50%. There's a lot more to come yet. And that means we still have to do outbreak settings, including retirement homes, congregate settings, and other ones as they arise. So I think we're going to be pushing that agenda pretty close for the next week, and then we already have a table that's looking at testing strategy and where do we go next to say if you're now going to test this, what are you going to do this one for and that one for, and then how do you open up for wider ones? So all the time looking how to maximize the testing capacity. At the same time, we don't want to go way over and end up having now people waiting for 6, 7 days to get results back, especially we still want to do our priority testing groups to make sure we get those back even within 10 to 12 hours. And I'm not going to name the list again, but you know what that is. So there's a good balance in here. So let's see how we do in the next couple of days with all this assertive surveying going on in the long-term care facilities and ongoing sample submission from all the 128 assessment centers in Ontario.
Next question.
Your next question comes from Cynthia Mulligan with City News. Please go ahead.
Hello, Dr. Williams. I was wondering if you could tell me a little bit more about community spread. The numbers that I've been looking at, if I'm interpreting the epidemiology report correctly, is they're slightly below 200 a day, and they have been for the last 5 days. But can you explain, or what is your theory behind community spread not dropping faster?
So, right, and again, I think you're pretty close there. If you take our 477 today and take about community still about, in my mind, more like around 55%. So that does put us over 200. So we've been nudging back and forth around there. So it is still perplexing to me that we're not making major headways going down on that, and it makes me wonder if people are not being less than consistent in their physical distancing, and if they were in close contact, they were not wearing a facial covering during those few moments when they could not maintain physical distancing. And I wonder if people are still, as we want to get down to that case contact management, and as we've had some already where we've asked some people who said initially no, when we get some information later, they said, well, okay, that was probably true. I didn't think much of it. And so there's a tendency to say over that period of time, to let your guard down and then get that exposure, and you find out that that group that you're with that you shouldn't have been with, you found out later someone was positive and you had assumed they weren't. So I think there's some ongoing transmission there, and we really, that means a consistent number. People have to really stick to the task, because the sooner we stick to the task, the sooner we bring this down, the sooner we can look at moving into the stage 1 of our post-pandemic aspect there. So it's something everybody has to do their work on, their part on, and I just encourage everybody to stay at the task. Just because there's a few sort of like business things that are doing things, we still say the 6-foot distancing, the 2-meter distancing is required, and hand washing, and stay at home if you can, and if you're out, stay out, and you go out and do your thing with distancing, and be disciplined on that. You still have to do that in there, or we're going to be in this plateau for quite a while. And sometimes some others have to remind people, saying that that's less than, you need to be consistent with that. So that's my plea, is stay at that. Unfortunately, I guess the weather is not as good as last weekend, so maybe more people will choose to stay indoors and not go out, and that might be helpful over this coming weekend.
Follow up?
My follow-up, doctor, is when you're looking at the results of community spread and where it's coming from, is there a consistent theme? Is it coming from grocery stores or people that have gathered with more than they should, or they've gone for a run? Is there any consistent theme on where people are picking this up in the community?
Well, that's a good question, because that's what we've been asking with our data analytic people and our public health people now to move into this fairly focused case contact management and to get that number. Remember, you saw we had somewhere there's about 35% odd pending and another 35 or so that community spread. That high number, we've got to bring that one down, because we have to say you're positive, so you got it from somewhere, and you look around saying, it looks like a lot of people got it from going from this establishment, this grocery store, or whatever. And then you can start doing that clustering, because you may say in your investigation, we found 5 people in the last week were actually on the same time in that facility. And you go in, you find the facility's been less than diligent. They've been casual and letting more people in. And so that could be an outbreak type modality. So you raise a good point, and that's where we want to get down to that kind of intense case contact management to look at those areas where the numbers may be staying up, not because community-wide it's spreading, but now there's a cluster group that we're saying, well, regardless, we decide to meet as a group of 30 or 40 anyways, and we did this and we did that, and you find those numbers are being driven by outbreaks within clusters. It impacts the whole one, so you want to be able to say, these are actually clusters that we can contain. The whole population writ large is doing as they should be. So we're trying to differentiate that. I'm not sure if that confused you, but to say how important the point you're making is, and we need to get to that kind of granularity.
Okay, we're going to move to our last caller.
Your final question comes from John McGrath with TVO. Please go ahead.
Doctor, the numbers for the last few days have been flat. I know you said that we shouldn't overreact to any one-day trend, but this has now been, I think, 4 or 5 days of what seems to have been like a pause in the decline. And I'm wondering, is this a cause for alarm, or is this something that is a sustainable level of activity for the next little while?
I think this, as I said, the bump today, you have to remember we went up from early in the week around 10,000 to 11 to 12,000 tests. Today we went close to 16,500. So if you know our positivity rate is at a certain percent, it's no doubt we're going to get that. Now, are those from actually exactly yesterday? They were processed yesterday, and which data, whether they're identified. And that's why I said these undulations are a little bit deceptive, including with the volume of test samples coming through. So you will expect as you get up to 17, 18, 19, 20,000, unless our positivity rate is really nosediving, for every the data here, for every 100 extra tests you're going to get, you're going to have 4 to 5 or anywhere 3 to 5% more positive cases in there, because that's our rate. And in the community side, it may be higher than the overall average. So you're going to expect that. So some of it's due to volume of testing, and the other is due to just changes in when the tests come in and when people show up to get tested and how they obtain that. So as I said, the trend's more important than the day-to-day jumps, and there's reasons why it has its variation. So I would say before everybody said, okay, we're really on a downward slope, we weren't. We're on a slow plateau. This is a bit of a blip. I think as you go over the weekend, we're going to see that settle down a bit again like we did last week, and then dip down again early next week with smaller volumes. So it gives you a little bit deceptive with the ups and downs. So then focus on the long trend, and we're going to hope to try and give that to you in a better way so that you can see the trend analysis, not just the day-to-day undulations.
Okay, follow up.
You mentioned, or I believe on Saturday, you talked about beginning a collection of race-based data, and I'm just wondering if you could clarify when that will start, if it has started already, and what you expect the use of that data to be from your perspective.
We're trying to put that in place. It's on basis of voluntary. At the same time, it has to go through a number of different committees and tables to get reviewed in there, because there's different parameters. Because Ontario we don't do that as a normal basis. in this situation? Do we have enough indications to do so in a voluntary basis and that like there? So we haven't formally started. We're still looking for approval because there's many different components that have to review legally and different ethics and different aspects there. So it's an area that as of yet has not started, but it's in the process to be reviewed, and whether that'll be approved in the over the next 10 days or not, we'll have to wait and see.
I understand that there's one more reporter that's trying to get into the question queue that's having a bit of difficulty. If the operator can just clarify how somebody can get into the question queue, that would be great.
Ladies and gentlemen, to get into the question queue, please press star 1. If you're on speakerphone, please lift your handset before pressing any keys. Haley, do you know who's trying to ask a question? Because I can open them up.
Yes, it's Jessica Smith-Cross from QP Briefing.
Okay, I'll open her up. One moment. Jessica Smith, please go ahead.
Thanks so much, and thank you, Haley. I don't know why I couldn't get through there. Dr. Williams, yesterday you spoke about declaring outbreaks in non-healthcare workplaces. Can you clarify under what circumstances the province or local public health unit would alert the public and the media about workplace outbreaks that occur?
So in general, with workplace outbreaks, when public health is aware, there's a suspicion of that and goes in and starts the investigation, the usual thing if it's a workplace, usually the medical officer of health likes to work in concert with the management of that workplace to fairly quickly and in a transparent way come out with press release and public information about the outbreak in their facility. What does that mean? What does it mean for the consumer if it's a manufacturer? What does it mean for other family members and people in the area? So we've always been fairly consistent on having that approach. Again, looking for a partnership between the manager and the organization and public health. And sometimes if it involves labor, you have to have Ministry of Labor involved. And sometimes if it deals with organizations that have international or beyond the boundaries of Ontario and production, especially in food and services, you'd have to work with federal partners. So each one has a slightly different variation, but the idea is to be open with communication and transparency to keep the public informed on the matter.
Follow up?
Yes, and I have the same question for the situation you described earlier where you could trace a few cases to, for example, a grocery store. Is that something that you could use the media to alert the public about quickly, perhaps more quickly than the contact tracing can work?
It's a little bit faint there. I think it had to deal with when we apply the same type of thing if there was something at a grocery store.
Yeah, I could. You spoke earlier about a case where you could trace 5 cases. You said, for example, at a grocery store. Is that another situation where you would alert the media that there has been, a cluster of cases at a specific place, a store, a grocery store, a workplace, to alert the media quickly to let people know?
Well, yes, and I think I got it now. Yes, thank you. As I thought it was. So that if in our case contact management, we find that there's a grocery store or there was some other event where we found a cluster of people, and obviously there was someone who was positive that might have impacted the group, we would want to generally go public with that because we don't know who all the people were that were in that grocery store. And you'd want to know that if you're in this grocery store or this facility, and I'm just picking on grocery stores, on this day, especially in these hours, you need to contact public health and ask for direction. And you may say, well, I was in there, and so maybe you have to be considered to be followed as a potential exposure because you could be an equivalent of a contact in that facility, or if you're in some sort of an event type thing. So yes, we would inform the public, especially if we didn't have if we had a list of everybody who's in, that would be easy. We contact the list. But if it's public, then you'd go public notifications so public can say, I was there. I need to go and get tested. I need to get seen. So that's one of the strong reasons we are transparent if we are aware of that exposure.
Okay, thanks everyone.